Hey,
Okay, now we're good.
right.
Take it away, Megan.
Awesome. Thanks, Marcy. All right. I'm so happy to be with you guys today. Just a couple of logistics and housekeeping things. So if you want to come off your video and engage and interact, that's totally fine. I know it's easier sometimes to just stay behind and not have the burden of being perceived. I'm going to try to keep an eye on the chat, however. And so if you have questions, you can raise your hand. You can come off video and wave at me. You can just interrupt if you need to. I will make sure that we have plenty of time for questions at the end as well. So if you don't feel comfortable interrupting, that's also fine. I'll leave space and time for that at the end. This is pretty dense content, you guys, but it's going to be really, really good stuff. And I'm hoping that you'll be able to walk away with some pretty tangible ideas and strategies that will feel like they are tackleable, and then we'll walk through how to work through things together. So this is Workforce 101. This is presented by Good Life University. And Good Life University is actually a collaboration between Good Life Innovations and the University of Kansas Department of Applied Behavioral Science. We've had a relationship for almost a half a century. So we are nearing that 50-year mark. And Good Life Innovations is a provider in the state of Kansas. Our history is in supporting people with really complex intellectual and developmental disabilities, but our mission meaningfully expanded about 5 years ago. And now, in addition to supporting folks with disabilities, we serve anybody who has a barrier to living with as much independence as possible. And we've included the direct support professionals in our mission as well. And this is really important because we can't do what we do without them, and realizing that and recognizing that they are very much the backbone of our mission has really helped us to drive meaningful change at Good Life. And then the university aspect really is helping us take what's working here and share it with other providers across the nation. So I don't need to tell you that the care industry has a pretty unstable workforce. In fact, it's been unstable for decades. This is a little snapshot of the instability of our workforce, but this is before the pandemic. So 5 years ago, 6 years ago, we expected and anticipated and saw direct care worker turnover that exceeded 50% or more nationally. Some agencies have come to us with 100% turnover. They don't get any one DSP or DCW to stick around for the entire year, which unfortunately was just not very uncommon. We also saw that about 69% were full-time, and those full-time providers had a little bit more than a 12% vacancy rate, which meant that even though they were working, that 79, almost 70% of the workforce was a full-time workforce, they were still vacant. Those positions were still vacant 20% or 12% of the time. And then as far as part-time workforce goes, that was more 30%. And this has been consistent across all of the work we've done, that 70-30 split, so that we've got part-time caregivers that have that, they're nearing 20% vacancy rate. And folks, we're going to talk about this a lot, but part-time is part-time for a reason, and really not ideal for delivering professional services. Over 30% of the direct care workforce left employment in the first six months, which meant only 40% essentially were employed in their caregiving role for more than 36 months. So pretty unstable, consistently unstable. And then COVID happened, and this really changed everything. Now we have a convergence of events that has created a little bit of a supernova. We believe things have changed forever and that they're not going to go back to how they were before. And so it's important to understand what happened and why it happened. It really sort of changed how we work and what we consider important as workers. And not surprisingly, 65% of all individuals who are looking for a job now say that working remotely is their first priority. And as you know very well, in the caregiving industry and working with folks who have long-term needs and require long-term supports and services, you can't really provide that care remotely only. We also saw that while congregate care, especially during COVID, wasn't ideal, it wasn't at home, it wasn't safe, there's still reasons why congregate care persists. And so we are seeing even more now than before, this sort of consistent reliance on congregate care approaches. This makes a lot of sense because it's the way that you can get folks to come to you or to a place in order to receive care and have supervision and higher ratios and account for intermittent needs. But serving people with complex needs in smaller and smaller settings, which is especially fueled by the final settings rule by CMS, this is going to be pretty, it's not going away, and it's definitely providing for additional layers of complexity within these, within the homes and programs. The other factor that changed is that baby boomers are retiring at a really fast rate. So every 8 seconds, someone is turning 65. This is fueling sort of an exponentially rising need in senior care. And some of the fallout related to that is that with over 50% of those with intellectual developmental disabilities self-directing their care and leaning on family caregivers, what we're seeing is with the rise in the aging population, this is kind of hitting like a double whammy. So we've got folks who are aging into need, which is typical as we age and bodies decline. But when they are serving somebody with an intellectual developmental disability, a physical disability, a brain injury, anybody who's relying on them, you end up needing to serve both of those individuals. So we've got a tall mountain to climb here. Remote work isn't going to go away, and the sucking sound you hear from the IDD industry is folks being called into the senior care industry, which is 70% private pay. And so competing with that is going to be real challenging. The other important component is this sort of deployment, I guess, or expansion of CMS's final settings rule. This is a new vision of care, and I don't think anybody really disagrees with how valuable this vision is. It's fueled by things that we hold very in very high value. So preferences for advocacy, for smaller homes, for being served in your own home, for choice and the ability to self-direct your care, the autonomy, the ability to make your own decisions and to have rights, to have your supports working around you instead of you being accommodated by or only having access to what other folks are going to offer. This ends up being something that we value a lot, but it also has really challenging implications for the caregiving workforce. And again, this isn't going to go away. So let's talk a little bit about the barriers that we have to making our vision of the final settings rule reality. As I mentioned before, we kind of take the position that congregate care exists for a reason, and that results in essentially the qualities or criteria that that congregate care has that small settings and small homes don't have, that end up making the gap in having consistent caregivers very challenging. So those barriers are the higher ratios. Essentially, more caregivers are needed to support the same number of people when everybody is in different areas. There's high reliance on sort of fractured, what we're going to call wonky schedules, and on relying on part-time care. There's increasing gaps in the care delivery, and that means sort of leaving authorized hours of support on the table because we can't provide a caregiver to deliver those hours. We're also seeing increasingly complex needs. Autism rates are on the rise. There's this co-occurrence of mental health and physical disabilities. The other reason why congregate care persists is we have little or no supervision or on-the-job training when you're in smaller homes. So we put people together so that the new caregiver is working with a veteran caregiver, and their supervision and interactions are supporting that job growth for the new caregiver. Now, when we've got smaller settings, people are working often alone without that kind of supervision and on-the-job support. And so we continue to sort of congregate in a lot of areas of the nation when we need to deliver care. Replacement staff are also not necessarily familiar with the individuals that they're working for. So there's a greater reliance on staffing just in case, in order to make sure the person who knows them is there. It's really expensive. There's high cost of living. Essentially, this is the buckshot of all of the factors that are standing in the way of making the vision of the final rule a reality. So what we're going to cover today is really our sweet spot. Good Life has been utilizing the strategies that we're going to outline for you today for nearly 2 decades, which is incredible, kind of hard to believe. What we've really worked on perfecting is how to get the quickest and easiest, sorry, my boss is calling me, trying to get the quickest and easiest implementation of those strategies into your settings so that you have the relief as soon as possible. What we're going to cover today are wonky schedules and why they exist, the ideal schedule characteristics. We're going to talk about different shift schedule types, and I'm going to outline for you what Good Life uses. We call them our 5 faucets, 5 staffing faucets. And then I would love to spend some time talking through our compensation strategies. That includes information related to how we calculate PTO and overtime. I'd also like to outline for you how you create your own staffing replacement pool and manage vacancies and workforce, workforce management. Then we'll look at some of the impact data, so what the results are that we've been able to achieve, and we'll go through our implementation strategies. So at Good Life, we're behavioralists. We really like to start with what we want to achieve. We start at the end and sort of work backwards from that. So what I've outlined for you here, and what I'm hoping we can do for you as a provider agency in the LTSS space, is set a vision for what the next generation of care is going to look like. This is what we're trying to achieve. So we want obviously higher satisfaction. That's not just for the people who are delivering the care. It's not for the agencies or the managers. It's also for the persons being served. We want to increase direct service wages. There's no emphasis on non-wage benefits that's going to take away the importance of raising wages and offering a living wage for folks who are providing this level of care. We're looking at achieving a lower turbulence, especially in the first 90 days when folks tend to turn over the most. We're going to be reducing the number of people involved in care. When we do that, we see direct results in improved care quality. So it's important, the more people that are involved in care, the lower the quality of care. So for that reason, we want to reduce the number of people involved in care. We'd like to have a bigger pipeline of talent. We want to see folks who are drawn to the caregiving industry, and we want them to be well-trained and on the job quickly. We really want to have lower vacancies and a shorter duration of those open positions. We don't want anybody working short, so not under your ratios, not with one caregiver for X number of individuals, but rather making sure that the ratios are met. We want the greater capacity for each of our caregivers to work extra shifts. Often they're working 2 jobs, so our motto here is if you want a second job, work for us. We want shorter work weeks and full-time, and of course we want to offer more time off. This is really about work-life balance. We think we can achieve all of this with little or no reliance on part-time caregivers. Again, part-time, low quality, they're part-time for a reason, and they won't fill in the extra shifts the way that your full-time caregivers will. And then we want to have an effective replacement staffing strategy, workforce management strategies. So here is a little bit of a summary of what we say when we're referencing a direct care worker. That's DCW. DSP is also used, DSW. I'm not sure what you guys use in Utah, but essentially these are the hourly employees who are doing the frontline caregiving for the individuals served. This is national data, and this is a pretty typical profile. Again, it might be a little skewed depending on your region, but this is from our research across the nation. And so what you need to understand is that 81% of those caregivers are female, that 63% are the primary breadwinner for their family. They are almost half of the time they're single, and that usually means that they're also providing care for either a children or multiple children or a dependent older adult as well. So being the primary caregiver, having folks that they're caring for at home, kids that they're caring for at home, and being the one responsible for bringing home the income for the family, it's a pretty big burden. And as a result, it's not surprising that over 40% of them have a second job or work 2 jobs during a certain period of the year. And like folks who are really sort of piecing together and working hard to make ends meet, they have challenges with housing, with transportation or childcare. We're seeing, especially in the coastal regions, it's not hitting as much in the Midwest where we are. I don't know about Utah, but it's we're seeing multicultural and very, very diverse folks coming into the caregiving role. What's most critical about this, and what I don't want you to miss the opportunity to understand, is that 50% of the caregivers are eligible for the same public subsidies that the men and women we serve are eligible for, because of how close at or below the poverty line is for the wages that they're making. So when they're bringing in just barely enough to get above the poverty level, 50% of them are not, and they are still eligible for those public benefits. They are definitely in need of every additional resource that we can send their way. And so this helps you understand, what do they want? Pay alone? Yes, absolutely. Everybody wants higher wages, but it's not the only thing. And especially now we're seeing what a meaningful wage is can be a lot more dynamic than just a high wage or a beefier paycheck. So these are the job-related amenities that are the most important to the direct care workforce. Again, from the research that we've done, they want attractive and flexible schedules. It's kind of what everybody wants. They want more and better days off, better housing, better transportation, the ability to work extra, especially when they need extra. They want work-life balance. They like to live close to work. So having a short proximity between where they live and where they work. Again, it cuts down on transportation costs and caregiving burdens and childcare and all of that. They want a higher pay frequency, which we're going to go into a little bit. And they really want useful benefits. And then we have a whole nother presentation related to non-wage benefits that can kind of blow your mind on a way to sort of redirect the dollar and help DSPs get more of what they want and what they need. But keeping that in mind as far as how to leverage wage benefits next to non-wage benefits in order to increase the dollar, anything to help. Okay, so most of our time together is going to be spent on these scheduling strategies. These are pretty unique and really fun to go over. So first, I want to present sort of the problem. This is what we call a wonky schedule problem. And I will say, you know what wonky schedules mean, right? It's when you've got hours that are inconsistent across the work weeks, meaning you're working different days and hours, depending on the need. Sometimes you're working really long hours and back-to-back shifts. when it's not consistent, one of the biggest problems that we see with these wonky schedules is schedule migration. So what we mean by this is it happens when one schedule at an organization is more appealing than another schedule at an organization. And so a good example would be, let's say, it's a typical like 3-shift situation, and you've got your day shift and then your evening shift and then your overnight shift. And because the day shift is more appealing, when one of those shifts opens up, even if it's just as wonky, people will still migrate from the evening shifts or the overnight shifts into that day. And so schedule migration is it's such a burden, because what you end up with is not actually knowing or going to market with the schedule that's actually open, right? So a more appealing shift opens up, and then you've got this ripple effect of folks moving into the more appealing schedule and leaving a vacancy behind, and then someone else is in a less appealing schedule taking that vacancy, and before you know it, you've lost weeks going to the market and hiring for that vacancy because you didn't even know where it was. So that delay, you end up in the worst scenario, because you're going to the market with the least attractive schedule and trying to attract new direct care workers to work at starting wages. So that's a huge problem, and wonky schedules are the root of it. Another problem with wonky schedules is your pipeline's dripping. Nobody wants to work a split shift where you've got one overnight and then two day shifts that are back to back. Nobody wants that in the first place, so that's why nobody is applying for that job. There's also too few days off, or the days are unattractive. Those days off are really unattractive. The schedules are unfillable, and sometimes in some of the cases we've seen, they stay open permanently. It's so wonky that nobody will work those hours. The schedules also end up being fractured, which contributes to longer vacancies. When you're working a split shift and you're advertising a split shift, it's no wonder that nobody is just lining up to come and work those hours. This also is a problem for your managers. So the ones who are burdened essentially and usually with building the schedules are working from their limited resource pool, often calling on the same folks who always fill in, and they end up accommodating the stayers. And we like to say a vacancy gets no vote. So when you're redesigning schedules and rewriting them week over week, first of all, that's an administrative burden, but also those schedules are probably being redesigned for the stayers and to meet the stayers' needs, which are very different than filling a pipeline and bringing a new and fresh direct care workforce onto the floor. So these schedules are inconsistent. They're reactive to pop-up emergencies, which always happen. There's often too many part-time roles, especially in the evenings and on the weekends, which are when managers are not present and they don't want to be called into work. But ultimately, there being almost no or little standardization across your homes puts a tremendous burden on the system, all the way from the home management to the HR team who's trying to recruit for those roles. So we have a problem with wonky schedules. Again, this is the Good Life way. We talk about what we're trying to achieve. So opposite of a wonky schedule, what we really want are consistently appealing schedules. So they're either consistently appealing by the schedule themselves or the pay that you use to incentivize somebody to work in something that's a little bit less appealing. We want these to be set and consistent and not rotating. We want consistency week over week, shift over shift, because that's going to result in little or low or ideally no schedule migration. We want fewer different people involved in care, because as we said before, as the number of people involved in care goes up, the care quality goes down. We want to cover our ratios effectively. We want to reduce the reliance that we have on part-time employees. Again, they're part-time for a reason. We want to offer more days off and more days off in a row, which is really, really critical. You can't just get 1 day off, 2 days off on the weekend and be totally recharged and ready to roll again. So more standardization. The schedules, the more they're standardized, the more they're going to appeal to the market, the same market that's internal as external. And it's got a lot of other great advantages as well. So let me introduce you to our 5 faucet strategy. Essentially, the idea here is it's not a one-size-fits-all solution. We would never advocate that the schedules that we're going to talk about today are the only solution that you have. But we do kind of order them in this way. So from the least ideal on the far side to the most ideal on faucet 5 side. So part-time, weekend, evening shifts, these are not ideal. A little bit better is a traditional 5-day work week. Consistently, this is where we see caregiving industry hanging out. What we're going to talk about today is the front back half 3-day, 12-hour work week. That's faucet 3. And we've got a lot more that we can cover in future sessions where we talk about the really ideal staffing strategies, which are live by, live with, live near, neighborhood staffing strategies, and especially the shared living or professional, what we call professional families. So ultimately, for the benefit of the direct care worker and those that we're serving here, we're looking at all of the factors that go into staffing with as much consistency and outlining all of those goals that we set out at the beginning. So this is a good example of a provider in, again, Good Life is in Kansas. We've been serving folks here since 1977, so we're coming up on a half-century anniversary. We serve about 500 individuals across the state of Kansas and Arkansas, and you can see this isn't a one-size-fits-all portfolio. We've got all 5 faucets represented here, but what I really hope you take away from this is that we're reducing the number of different people involved in care. We are absolutely reducing our part-time reliance. In fact, this looks, right now it says 3.7 on the slide. We are down to like sometimes less than 1% of a part-time workforce here. It's really important because part-time positions have 2 times the turnover. They are chronically open. They result in all kinds of care concerns. They're expensive for the organization. They're really expensive for the individual served. And and our approach is really different. So we've got 800% less than the national average as part-time workers. Okay, so these are the highlights essentially of a 8-hour day, 3-shift approach. This is a 40-hour work week, essentially Monday through Friday. I'm going to have you guys just engage with me just a little bit, and I want you to do like a thumbs up emoji if you're familiar with this shift and your agency uses it as I go through this. So we are looking at 5-day work week, 8-hour shifts, 3 shifts a day, right? 7 a.m. to 3 p.m., 3 p.m. to 11 p.m., 11 p.m. to 7 a.m. The problem with this approach is pretty extensive. There's hidden vacancies. I'm going to show you the math on that in a little bit. The shift changes happen during the most challenging transitions of the day. So in the middle of the morning, as people are getting up and getting ready to roll out, that's one shift change. The next one happens at the end of the school day, and then the next one happens around bedtime. So this is pretty tough. Call-offs are really high for this schedule. The result is obviously and sort of necessarily a reliance on those part-time workers, what we call weekend warriors. These are folks who work in the evenings, split shifts or partial shifts on the weekends, essentially whenever managers aren't available and would not like to be available to work. These are the care workers who have very, very little capacity to work extra. So even if they can take on a little bit more, they won't or can't do a whole shift because it leaves no time to do life. and you're creating a ton of need for PTO. When you work 5 days a week, you only get 2 days off. It's not enough. And so you have to pay them to have PTO, which is a self-inflicted wound, because for every caregiver who's not showing up for a shift, you have to find somebody to cover that shift. It's different than manager positions or a C-suite, for example. When I need to be out, there's nobody who's doing my duties one-to-one exactly. But when a caregiver needs to be out for things that do come up, we have to replace that caregiver. We can't go short on our staffing ratios. People need to be delivered care. So there's a lot of problems. We, as you see from our portfolio, we have, I'm mapping it, 12, almost 13% of our workforce is a 5-day Monday through Friday work week. But it really can cause a lot of instability and a lot of challenges if it's used too much. The other problem is with part-time and weekend shifts. So these are very unstable. It's when call-offs happen the most. Vacancies are really hard to fill. And like I said earlier, they're twice as vacant. They're open twice as long. They come open twice as often. It really these workforces contribute to manager burnout because they are the ones filling in for those gaps. It also creates a lot of your overtime costs. So when somebody is filling in for a part of a shift or a shift on the weekend, it's usually in addition to the work that they've already done. And overtime costs are really expensive. The result is high burnout. Often care gaps are having to work short, which is unfortunate. And then when managers and trainers aren't present, there's definitely the more likelihood for care concerns. So this is the most common schedule of, approach for like backfilling evening or weekend times, but it is not the one we want to look at. So I'm going to introduce you to what we call a front back half 3-day work week. This is our base schedule. You saw about almost 50% of our 5 faucets are of our workforce are actually in this category. So here's how it works. So it's 12 hours a day, 3 days a week. The work week starts on a Monday, usually starts on a Monday and ends on a Sunday, and I'll explain why later. And then the work week is so 3 days, right? From Sunday and 2 days out of Monday, Tuesday, Wednesday for the front half of the week. Or if you're working on the back half of the week, it's Saturday and 2 days out of Wednesday, Thursday, Friday, right? So you have front and you have back, you have day and you have night. And that covers all 24 hours. This is a baseline schedule. Usually there's the ability to throw in overlay staff, but essentially this is how it works. I'm a visual learner, so I have 2 slides visualizing this. So hopefully this will help you too. So a typical schedule for front and back half nighttime schedules. So working 7 p.m. to 7 a.m. 3 days in a row for those 12-hour shifts, and then you're off for 4 days in a row. Alternatively, the back half works 3 days, Thursday, Friday, Saturday. And that gold that you see on Wednesday is a direct care worker essentially opting in to picking up an extra shift throughout the work week. We're going to talk about the incentives and why somebody would want to do that. They still have 3 days off. You can see 3 days off in a row. That's one way to do it. Here's another visual. This is across, let's say, like a subset of homes. And essentially you have a front half direct care worker working in home A, home B, and home C. And you can see that Wednesday has a float direct care worker who will move across those homes and still work 3 days in a row, but has enough experience and enough quality in their caregiving to be able to work with that many different individuals and do it effectively. And so they will work then Tuesday in home B, Wednesday in home A, Thursday in home C. And even though there's a split and the front back and the front half and the back half workers each have in home B and home C, all of their days off are not in a row. Sometimes this is a really appealing approach, having that break in the middle. So that's just another way to look at it. But here's the benefits. So these are very solid and tangible. Realistically, and like bottom line, your labor costs will be reduced by 10 to 15%, delivering the same ratios of care if you move from a 5-day work week to a 3-day work week. There are fewer shift transitions, especially ones that matter during the times of day that are really critical. So working full-time in 13 days a month gives you 17 days off every month as a direct care worker. It's kind of unheard of. There's very low rate of schedule migration because the schedules are very consistent. Front, back, day, night means you've got the same schedule. It is standardized across your agency. There's a better experience and coverage for evenings and weekends because they're part of the typical shift. They're not separate. They are not less ideal schedules. They're part of the typical work week. And we've even got folks who seasons at GoodLife, especially where we've had waiting lists of people who want to work on the weekend. And I'll get into that a little bit more later. Ultimately, there's fewer different people involved in care, which accomplishes what we set out to accomplish. More full-time and fewer part-time employees. At GoodLife, our part-time, I think you saw, was did I have that up there? Yeah, 3.7. Usually it's in the sub to near or around 1%. The work weeks are really flexible and offer really easy shift trading because you're trading shift for shift, not part-time or not part of a shift. You're staffing essentially in these homes where you've got a front half team and a back half team, and their collaboration and overlap is really incentivized. So it ends up being super flexible for the employees to find somebody who can take on their shift when they need to be out unexpectedly. And these folks are utilizing a front back half 3-day work week, offers 40% more capacity to work extra without working longer days. So still getting extra, not working any more hours in a singular day, but being able to pick up a shift. I've got a graph on the next slide that's going to help map that out for us. Ultimately, when you're working 3 days a week, there's fewer trips to work. There are fewer days that you have to rely on childcare, fewer PTOs that are needed to fill shifts, less shifts to fill overall. And when this schedule strategy is combined with our premium pay strategy, the compensation and the schedule come together to make a really, really impressive outcome. So I want to talk a little bit more about the 40% capacity to work extra. One of the biggest hidden vacancies is represented here. And this looks like a super boring graph, but it's actually very, very cool. So the gold line that you see is our front back direct care workforce. So these are the folks who are hired to work 36 hours a week, okay, 3 days, 12 hours, 12, 12, 12, that's 36, it's full time. You can see that they consistently work more than their full-time schedule. So every time that they are above that 100% bar, they are working more than the 36 hours they were hired to work. What you see the blue line is actually and you could probably pull your payroll data. I recommend that you do because it's one of the easiest things to track and to mark. But the data from your direct care workforce that's been hired to work 40 hours a week across 5 days of the week, if you pull that payroll data and average the actual number of hours that they worked each week, you're going to see more than likely that they have covered 80% of the hours they were hired to work. Again, if somebody is working a front back half 3-day work week, they are actually covering 106% on average, 106% of the hours they were hired to work. The delta between getting 80% of the hours that somebody was hired to work and 106% of the hours they were hired to work is massive. It's massive. And I think there's a lot of hidden vacancies that are wrapped up in this one graphic. But ultimately, if somebody's hired to work 5 days a week, they will often not work those full 40 hours. And so we need to be aware that this vacancy can happen, hidden vacancy. Okay, I also want to explain a little bit about our superimposed workforce here. So because of having consistent schedules at Good Life, consistent standardized schedules, we have the ability to cover shifts, so vacancies that are unexpectedly open, by using what we call a superimposed workforce. I'm going to talk more about this later, but it kind of relates to this as well. We're easily able to hire and train direct care workers to fill in those vacancies. And so because of the easy shift trading, when we know we have a vacancy, we're going right to the direct care workers in that superimposed bucket who have already been trained and who are already ready to fill in, and who often they are hired to work a full-time job just covering known vacancies. And what it ends up doing is covering the openings, the vacations, the call-offs, without causing any interference at the home level, which is really tremendous. Okay. Let's talk a little bit about PTO. I said it before, we call PTO a self-inflicted wound. Anytime somebody is using a PTO as a direct care worker, it's creating a shift vacancy and an opening. So when you and I tangibly, when we call off, nobody's sitting in our chair doing our work, but our tasks get absorbed, but direct care workers' tasks, they have to be replaced. We know from earlier too in the discussion that our direct care workers want a lot of time off. And so what we're looking at is how do we deliver the most time off possible? So here, this is a little bit of math for you on this slide. So we have the front and back 3-day work week when you're off 17 days a month, and you're only working 13 days a month. That automatically gives you, before any PTOs are calculated, 208 days off every year. So 3-day work week before a single PTO is offered, we're offering 208 days off, which is incredible. If somebody works 4 days, instead of the 3-day work week, if they pick up that extra shift, we're giving 156 days off before PTO. The 5-day schedule before PTOs offers only 104 days off. And let's just say you have like the best PTO policy. It is so generous. And yes, you have to fill all of those vacant positions when any direct care worker takes a very valid and reasonable paid time off. We'll fill those roles as needed. But let's just say, I think like the nicest, best, greatest PTO policy we saw had somewhere like 60 days paid off. Usually it's more like 30. So if you add that 30 to the 104, we're being able to offer at the best, at the most, 134 days off, which still comes nowhere near what we're offering with a 4-day or a 3-day work week. Just let that sink in. It's so much time off. We are literally empowering our direct care workers to take almost 60% of the time off and only work 43% of the time. It's totally inverted when you look at a 5-day work week, and just how many natural days off there are. And those days off are only happening on Saturdays and Sundays, which is great. People definitely want time off on the weekends. But our care doesn't stop on the weekends. It doesn't stop. It doesn't end on Friday at 5. Okay, we are rolling right along. Let's shift now and talk a little bit about our compensation strategies. So I want to introduce you to premium pay strategies. This is a common holiday and weekend pay approach. It is for more information. I'm gonna hook you up with all sorts of information on this one, but it is related to a Department of Labor, that section and provision there right in the middle. But essentially, premium pay is when you as a provider agency and a payroll agency chooses to pay premium pay wages for work that's done on the 6th or 7th day of the work week, or what are designated as special days. So 6th and 7th day of the work week is really important, and it's why we start our work weeks on Monday and end them on Sunday, because then Saturday and Sunday are the 6th and 7th day of the work week. The difference between premium pay and a differential is really, really important. So pay differentials happen a lot. We often see those utilized to make folks more incentivized, again, to like work wonky schedules or in very difficult care settings. But the important thing about premium pay is that when you opt to use premium pay, which is time and a half, when you opt to pay time and a half on the 6th and 7th day of your work week, it does not go into the calculation of the base wage that's used to calculate overtime. This gets really complicated, but I hope you can stick with me. So essentially, what happens when you choose to pay time and a half means that when you get ready to calculate overtime for that individual, the premium pay isn't factored into their base wage in determining what overtime is. The other really important thing, and this is the second factor, is that when somebody is working a premium pay day, those hours also do not go into the calculation of overtime. So not only does the wage not impact the base, but the hours worked they essentially act as a credit toward any overtime that's already been paid. Okay, so when somebody decides to pick up an additional shift in the middle of the work week, and let's say in that one graph I showed you where somebody worked overnight Wednesday, Thursday, Friday, Saturday, the Wednesday hours are paid at the base wage. And I'm going to talk through how all that works in a second. And then in addition to that, those hours, that 12-hour shift, it is a credit against any overtime that's worked on the weekends. Okay, when they work on the weekend, essentially they're working Wednesday, Thursday, Friday, 12 hours each day. So that's their 36. And then yes, they're getting overtime on the weekend, a Saturday shift, again, 12 hours. But those hours are already being paid at time and a half, and the Wednesday hours have been credited from the time that's worked on the weekend. This works so well, especially with a front back half work week, because we're able to combine the incentive of paying time and a half on the weekends, which is time when managers don't want to be working anyway, and get the value of that dollar and incentivizing middle of the week work without just astronomically blowing out how even heat-seeking overtime missiles, the ones who will just always work, always, always, always. We've got 4 days in a row, and then we're ensuring that they get more than 2 days off each week. I hope all of that is making sense. It's pretty complicated, but it's also really tremendous. So let's walk through the math. And I know nobody pays $10 an hour anymore, but I was an English major, and this is math I can do. So again, we've got the base hourly rate of $10 an hour, and we've got 24 of those hours that are worked at the base rate. Okay, so we're using the example of a back half. So Thursday and Friday, 12 hours and 12 hours at $10 an hour. That's going to be $240. And then you have 12 hours Saturday shift that's working, where the direct care worker is working at $15 an hour, because that's time and a half, and that's going to equal $180. So 240 plus 180 means that the total paycheck for that pay period, 1 week, is $420. You divide that by the 36 hours they worked, and you'll see that the average hourly rate is $11.76. So instead of that $10 an hour base wage, you're actually saying, no, your average hourly wage is $11.76. Then when somebody picks up an additional shift on the weekend, you've already budgeted for that overtime at that rate. You've already budgeted for them to work at that rate, so there's no additional overtime costs. So hence the waiting list to work on the weekend, because our workers knew they were going to get time and a half. And that was very appealing. The last column on this slide of that average hourly company costs is in the event that that individual also picks up a weekday additional shift when they're working Wednesday and Thursday and Friday at that base wage, and then you're paying them premium pay, which is time and a half for the one shift that they do on the weekend. The cost to the agency, the company who's the employer, is actually even lower, because that Wednesday pay is at their base rate, because it's not overtime. It's not overtime yet. And the overtime they're getting ready to work is a credit, right? So they have $11.43 is going to be the cost to the agency. So essentially what we're able to do here is you say how much it is that a meaningful wage would be, and we can essentially back into the right base rate and premium pay rate that gets you that incentive. So it's taking the same dollars and just redirecting them to the direct care workers. Okay. One of the biggest things about this is the capacity to work extra, which we talked about a little bit. The front back 3-day work week, they're essentially picking up one full shift weekday and one full shift on the weekend, but that column on the end showed you're not experiencing any greater costs as an agency for that to happen. So you're able to incentivize extra work. They want to work it because they need the extra money. They still are getting 3 days off, even if they work 4 days in a row. And it's not any burden on us because we built it into our payroll budget. So there's no losers here. It also really eliminates highly unstable payroll costs. So when we're working with agencies, we typically see that unbudgeted overtime is typically between, it's honestly, it's pretty astronomical. To budget for overtime is interesting. And we see some folks who have just massive line items for their overtime budget. But when you utilize the system and standardize the schedules, that unbudgeted overtime is usually between 1% and 3%. Again, with Good Life, like part-time workers, it's very, very low. We have almost no unbudgeted overtime expenses, which is really, really great for payroll costs and predicting expenses and reporting to a board. The other thing is that weekends become the most desired workday, because you're already saying, no matter what, we're paying time and a half on the weekends. That means that there's 50% fewer shifts to fill compared to the weekdays, because folks are incentivized. And because we've broken it out, we know that a standard team, a team that knows the individuals really well, is going to be working on a Saturday. And that team is also a different team, but also a full-time care team is going to be working on Sunday. And having that kind of consistency in care is really great. So part-time weekends are hired with the base of, for example, $15 an hour, and then the weekend premium pay could be $22.50. And again, their base wage, if they picked up a weekend shift, or a weekday shift is going to be at that base wage rate. So what I'm advocating for is that you consider overtime being budgeted in and included while you're establishing your wages so that you can pay that premium pay in advance and reflect to the worker that their value per hour is higher and their paychecks are going to be higher. This is pretty, I mentioned from the beginning, pretty dense. And so if you want to hear more about this, we did an entire podcast. Our CEO met with Jim Holland, who's an attorney, works for Fisher and Phillips, which is the largest law firm in the country, I believe, who focuses primarily on labor work. And so these guys are resident experts, and they really dig into the legality and the nuances of premium pay. You can find this episode a couple of different ways. If you go to mygoodlife.org and you click on a video, I think it's a video library or resources, there's a link to all of our podcasts. And then goodlifeu.org is another place where our videos are being transitioned into a new website, which is terrific. And I believe that podcast is available there too. It's a video podcast and audio. They're available wherever you get your podcasts. All right, let's talk for a little bit about what happens when people call off. The pitfalls, again, for traditional approaches, that 5-day work week. When somebody calls off, a manager is responsible. And usually they're calling the same folks over and over and over again. And ultimately are left fractionalizing the schedules, making the schedules even more wonky in order to get folks to fill them. Sometimes they even have to do the work themselves. The really, really good caregivers get called by all the managers. So no matter which home they're assigned to, if somebody knows somebody's a really good caregiver and that manager has a call off, they're going to call that really excellent direct care worker. So they're ended up being pulling from all directions. No one is talking to the other, so they don't necessarily know, but that direct care worker is getting burnout and fast. Often paying for PRN or substaff, they won't work when you need them to work because they're PRN for a reason, and they work when they want to work, not when you need them to work. Staffing pools are also really, really expensive. There was a terrible example of this in Iowa, where a staffing agency essentially went in to a community and offered $20 an hour for their direct care workers, hired all of the direct care workers away from the agency, got them essentially to sign a non-compete so they couldn't go back to the agency. But then the agency had no direct care workers, had to hire everybody through the staffing agency, and they were charged $30 an hour for those direct care workers. It's just astronomical. So avoiding staffing pools wherever possible is a really, really good best practice. Also, full-time direct care workers who are working 5 days a week, they can't and won't pick up a full shift usually on their 1 or 2 days off that week. So maybe they'll do a partial shift, but ultimately, even if you do find a replacement staff, they're not highly likely to be vested in the individuals who live in that home who are being cared for. So we're looking for ways to avoid these pitfalls. And I mentioned a little bit ago, but our replacement staffing strategy, we call it a superimposed staffing strategy. We're essentially overbooking the airplane. So like with Southwest Airlines, for example, like you'll buy a flight and then they will know full well that not all of the passengers are going to show up. And so they'll go ahead and overbook that flight. And folks might get bumped, or they might actually get onto a flight because somebody doesn't show up. We do that similar strategy, but with our direct care workers. It's made possible because our schedules are standardized. But essentially what we're able to do is by over hiring and anticipating, planning on those vacancies being open, we even kind of, again, this just kind of came down to math. It felt like no matter how big our agency grew, we still knew that X number of direct care or X percentage of direct care workers were going to call off. We always had the same number of openings, vacancies, even when things grew. So sharing the staff wasn't the problem. Having more staff wasn't the problem. Real life really, really happens. And so the way we handle this is by hiring an entire replacement staffing pool to work as a superimposed workforce for our own homes and programs. So they're hired, superimposed workers are hired to work full-time, 3-day, either front or back half of the week. And those are layered on top of our other positions. So when natural vacancies occur, we have our superimposed waiting to be told where they need to go. Essentially, all these folks are hired in a payroll bucket, lovingly named superimposed bucket. And by the end of the pay period, we're wanting to see all of the hours assigned to that superimposed bucket end up being 0 because we've pulled those hours and dropped them into the homes that had the openings. This workforce strategy is really designed to fill about 80% of the known openings. And again, there's a math problem there that we can help you figure out. Because what we also want to do is not cause excess ratios or real bad overtime. And we want to allow for folks, essentially 20% of the openings, to be there in case our direct care workers want to work extra. So we don't want to hire superimposed to work when we know that we can find direct care workers who are willing to work that 4th day of the week, still get 3 days off, and who want the extra funds and the extra work. So again, our motto has been, if you want a second job, work for us. We can do that without it being a burden on our payroll, and without burning out our staff. So this superimposed employees can be new employees, which provides also a way for them to experience choice, employee choice. When they get to interact with a home and a manager and the individuals in that home, it's a win-win because the manager is going to put on their shiny shoes because they want to keep the best of the superimposed workers or get those superimposed workforce, the employee choice. They want to be chosen. They want to be the place where the really good workers want to come to work. And ultimately, this is another good way for the superimposed staffing to kind of gather information on the quality of the homes and help the agency improve the overall working conditions. So we hire, instead of hiring managers or designating capacity for our managers to make the schedules, we work from the top down. And this is really, really, really important. We hire a workforce coordinator. At Good Life, 500 individuals served. We have a staff about that much with our shared living, but about 300 hourly workers. We have 3 workforce coordinators. So what they do is they collect vacancy data, they determine the need within the homes, they hire, and they manage all of the superimposed workforce and work through the employee choice program. They track all of the unassigned hours so that they can help control excessive payroll costs. We're not just giving overtime to anyone willy-nilly. We're utilizing our system and our centralized approach and our standardized approach to make sure that that not any one worker is being overworked and that our superimposed are being sort of distributed evenly. This is also make sure that the replacement hierarchy is enforced. We're not having managers call one off to X, Y, or Z direct care worker. We're really wanting to improve the experience of calling off, along with sort of the manager's experience of having their vacancies filled. So we handle that all at the centralized level. We're also ensuring the integrity of our master schedules, that no one house is running away with all of the extra workers. When a manager decides that a direct care worker is not best for their home or their program, I don't know about you guys, but sometimes they have this they don't give that worker back to the agency. They will just ride that pony over the cliff. They will just keep on with it forever, and until the worker quits, right? It's not a good fit. And instead of that becoming a value add to the agency, sending that worker back to be placed in a different home, managers may just run away with what happens with those workers. And ultimately, soul lost is a soul lost, and we need all of those souls to stay. So our workforce coordinators also improve the managers. They approve the hours that the managers are allowed to work shifts, direct care shifts. They're collecting, therefore, the excessive work data for both the direct care workers and the managers. They're gathering that quality intel from the homes and programs, and ultimately significantly reducing the amount of time spent on just managing a schedule, just filling in your call-offs, going through that dreaded, okay, again, somebody's not showing up today. Who am I going to get to come and cover their shift so I don't have to work their shift? By managing that all centrally, we've got this one-stop shop essentially for hiring, training, and replacing direct care workers agency-wide. Okay, I'm going to pause for just a second. We're almost done. I just kind of want to walk you through what an implementation plan would look like. Let's say these strategies are like, yes, it's a no-brainer. Of course, we could totally benefit from these sort of new and fresh takes. What do we need to do to make that happen? This is our sort of track for 6 months to having greater capacity. Congrats. You're done. First box is almost done. This is essentially free training because we see how desperately, how hard it is to staff in this day and age in the caregiving space. So Workforce 101 is our way of sharing what we know and what we've seen with you guys, and learning along the way. We learn a lot by working with folks. Before we ever move forward with implementation, we want to make sure that an evaluation is done and that these tools and resources, these strategies will actually work for you. So in order to assess that, we have a site review process. This is usually virtual because of COVID. We can do this virtually. It's about a half a day of us asking a lot of questions about the way your system currently works. And then we go back on our end and say, okay, evaluating what we learned against what we know, and deciding whether or not, yes, ultimately, yes, we think that these strategies can make a really big difference. Then we would work with you to essentially design a small subset, usually not more than 8 or 10 homes, and schedules where we would essentially do a comparison. So to analyze what your staffing strategies look like now, and how this is like payroll, schedules, number of open shifts, it's so much data, and it's really fascinating. But essentially to be able to compare what you're doing now with the tangible walkaways from, okay, if we were to implement these strategies at your organization, this would be the bottom line that you could expect to have. It's pretty conservative still, but at least it says, okay, that's an ROI that's worth moving forward with. And again, at each one of these steps is like, if this is not going to win and not going to make things better for you in the long run, then we're not going to go for it. But then we can help with implementing. So let's say we get the green light, it's worth it. I really recommend that you lean on our team for help with this, because it is absolutely where they sing. They've done this enough. It essentially streamlines and makes it accessible, all of the finance and HR prep that's needed, the marketing and education of your stakeholders. We don't want to lose a single direct care worker in this whole process. Getting support with the recruitment and hiring aspects, workforce management, creating that staffing pool we talked about, communicating with existing versus your new direct care workers. We've done it over and over and over again, and have all of the tools that make this process really, really streamlined. that's the coaching support that we can then offer. And then at the end of the implementation, we review to say, okay, what was the impact? Did we accomplish that? Is it actually giving you year over year savings? And if so, then how do we extrapolate that and equip you to be able to roll it out to the rest of your agency without our help, hopefully, so that it is really sustainable and walking you toward that 6 months of support. Okay, impact data. Let's show you what we've been able to accomplish. So these are some of the results that we have been able to experience. Again, we don't really share anything that's not working. I think that's probably a good thing. We really only teach or share what we ourselves do. And so teaching what we do feels really good. This is a snapshot of our workforce dashboard. And I just selected a couple of times in the little slider up at the top, a date range, so that you can see behind each of these cards is additional data. But what you can see at our organization, we're receiving 106 applications every week. That's for 300 or so direct care worker positions. We are averaging from the days that an application is received to when that person is hired, 4.4 days. And 9.5 is the number of days between when somebody is applied to when they are trained and ready to work, which is incredible. You can see our vacancy rate without our replacement pool. So this is without our superimposed staff. We'd have about a 16% vacancy rate. But with that replacement pool, we have just under 1% of a vacancy rate. So this indicates that every shift is being filled, almost every shift. We see the direct hours per day per client. So this is the number of different or the number of direct care hours that our clients are receiving. For consistency, we're looking at almost a 98% full-time workforce, which leaves 2.5% or so of part-time workers. The hours worked by stable direct care for Good Life, we call them DSPs, direct support professionals. They're working an hour, 0.6 more than they were hired to work, which is great. 82.3 of the hours filled are filled in the department that worker was assigned to work. So they know the individuals that they're caring for. They're not jumping hither and yon to anywhere that there's a frantic need, which means our average number of different people involved in care is 6, which is really, really great. Across a singular week, especially with the folks who have really high intensity needs here, that's tremendous. We have really high satisfaction rates. Our bad overtime is at 1.6%, and our average DSP rate is at 18. It's actually up to 1860, almost 1870 an hour now. The number of hours that managers are covering shifts is 1.26%, which is amazing. That leaves managers time to do what they're supposed to do, which is manage. When you look behind the DSP pipeline card, this is what you'll see. This really it's us being able to weigh how well we're doing in any given moment with the stability of our workforce. And I want to kind of call your attention that in the last 90 days, we've lost 47 DSPs, but we hired 60. So that gives us a net gain of 13. And you don't get into a bucket overnight. You have more who leave than are hired every week, week over week over week over week. And that's why you feel like it is like you're in a bucket, like there's no hope whatsoever. But we're seeing this shift now, and coming out with a net positive of 13 is tremendous. This one's also really cool. It's a little bit messy, but if you look at this openings graph here in the middle, you can see the delicate balance between our total openings that replacement pool that we have and the specific program openings. So right here where you're seeing all of the lines converge into one that's what we want. We want the same, so we want the total openings to not be exceeded by the replacements pool staffing, like here. We also want the program openings to be at the same level as our replacement pool openings. So things are not always great, but when they all converge, that means we're really optimizing the schedules and the pay and the replacement staffing, and it's working really, really well. So this is just a quick list of all of the providers that we've had, that we've been blessed to be able to work with, impacting over $1.3 billion of payroll budgets in the nation. And this is some of the results we're getting. So we're definitely seeing increased manager satisfaction and an increased applicant pipeline. We're seeing call-offs and openings and vacancies go down. We're shifting that full-time, part-time ratio really away from the national average and averaging more like 94, 95% full-time, 5 or 6% part-time. And like you saw at Good Life, 2% for us, 2.5%. And within the same payroll budget, we've been able to raise the hourly DSP wage, or the direct care worker wage, to somewhere between $2 and $3 an hour. Again, within your same payroll. It's just how we're leveraging that dollar a little bit differently. Okay. So I'm going to leave you with a couple of important questions that may be able to help you decide if these are valuable to you. And I think we're going to share the slides and hopefully the recording. If you're interested in learning more, you absolutely are welcome to reach out to me or a member of our team. Here, let me put my contact information up. We'd love to hear from you. And yeah, I think that's all I have. So if we've got questions or you want me to go back and cover additional information, we've got 8 or 10 minutes to be able to do that. Thank you guys for your attention. Hey, Jody, if you want to unmute yourself and ask your question, go for it. I cannot unmute you. Yep, you got it.
I was just wondering, do you have the types of programs you have? Are they all like residential homes? Do you have day programs? If so, do staff cross those various programs? Like if they're working 12 hours, some hours in days, then go to the residential?
Right. Good question. Yes. So it definitely, the strategies are not reliant on you having a day program, but if you do, all the better. Because yes, we at Good Life end up sharing our staff. They start at the home, they travel with the individuals into the day program. We're really moving more toward day services without walls. So it's supporting those individuals while they're in the community. And then moving back with them into the homes for the evenings and during those transition times. The percentage that you saw in our 5 faucets where folks are working those 5-day work weeks generally are like if we had center-based trainings or enrichment activities or like center-based activities, that's going to be where those individuals are, or those programs essentially are staffed Monday through Friday. But for the most part, our goal is to say, okay, you're receiving wraparound services both in your home and in the community, and we've got the staff to support you in doing that. Does that answer your question?
It does. Thank you.
Yeah, sure. I thought I saw another hand up.
Yeah, Megan, this is Sandy Smith. I have a question.
Sure.
So we actually don't provide like a residential or any group home type services. Do you have strategies just to improve the workforce in day program settings?
In day program settings only. So
Right.
the folks are coming from their homes. And what are the hours of your day programs?
So the individuals typically come from 9 in the morning to 3 in the afternoon.
Yeah. Yes. Let me ask Mike. I think yes, but I want to double check because you're not able to leverage like the weekend premium pay. It might not. Let me think about how that would work. And there's not 12 hours in those days. So we are able to staff our day programs uniquely, I think, because of the 24/7 approach
Right.
here.
Mhm.
But I have some other ideas that I might share with you, Sandy. Especially if your workers are if they're direct care workers and you're looking to make your dollar go further, there's some non-wage benefits that might be really appealing to those folks.
Thank you, Megan.
Sure. Who else?
Another question.
Yeah, Jody.
When you implemented this, I'm guessing you did not have people working 3/12s, like across your agency. How long did it take you to move to where you had those consistent shifts for people who just can't change their schedules, to be able to do that? Or
Yeah.
what did that look like?
Yeah, so that implementation is really, really important. Best case scenario is, look, we're not looking to like lose any of your direct care workers, and sometimes their schedules work for them the way that they are. I think what we're advocating for is not letting the stayer's voice overpower the agency's ability to go to the market with the best hourly rate and the best, most consistent schedule so that you can get and attract the best direct care workers. So in those cases, usually there's 1 or 2 homes that step up and they're like, we are in a bucket. We are struggling all the time. Let's go. Let's give it a shot. And if there's any workers in those homes with whom the new strategies don't work, they have a role, they have value, and they're kept in the agency, just move to another home or program. Usually what happens though, and I've heard this kind of across several different case studies, is once they get going, though the other managers across the agency are like, when can I have that here? Because my workers want it. They're also getting paid more because the premium pay, if that's implemented right alongside it, then they really work together to incentivize the working on the weekends, the longer shifts, the more days off. There's a communication strategy there that's really important to make sure you get right so that we're not necessarily losing folks who might benefit. Change is hard. Change is just really, really hard. So knowing how you're going to walk through that communication strategy to maximize as many, like retaining as many folks as you possibly can, it's really important. So leaning on a team who's been through it hundreds of times is definitely a good idea. But hopefully you get the waiting list like we've seen where other programs are like, I didn't think I was going to like, or workers, they go, I don't think I was going to like it, but I can't get enough. Like, I love it. It's so good. I wish you had done this a while ago. We had one gal with an agency in Iowa who said she's been an operations manager for decades. And she said, this is the best decision we ever made. They're retaining their staff longer. The satisfaction rates go up. So it's tricky, and I won't say it's easy necessarily. Change is not easy, but it is worth it. And it will build inherent structural stability, which is needed now, I think, more than ever, especially in our challenging spaces. So I hope that helps.
Yes, it does. Thank you.
Mm-hmm. I've got 60 more seconds.
Megan, I have another question. This is Sandy again.
Yeah.
How do you see this style of workforce working in a college town where we're having to work around staffing around college student schedules and things like that? Are you attracting a different worker? Are you relying on non-college students?
Not necessarily. So we have a lot of different regions, but one of our bigger regions is in a college town. So Douglas County, Kansas is the home of KU. Lots of basketball happens there. You've maybe heard the Jayhawks. It's a college town for sure. And while I guess they weren't very good in March Madness this year, to answer your question, it really works for students. And so sometimes there's a student who just wants to pick up 1 or 2 shifts here or there, but we find some of our best workers are able to rearrange their college schedules to work really well with the front back half approach. And it's not necessary. So like several of our other regions, Johnson County, Sedgwick County, they're not college town communities necessarily. So yeah, I think it appeals to a lot of different segments of the population. I wouldn't say that a student or a college town is more than one, but it's definitely not excluding them. There's values there too.
Okay, thank you.
Mm-hmm.
Megan, thank you so much for providing this
Sure.
education session. I feel like you've just provided a wealth of information. And as Marcy said, we'll have it available on our website. We'll let people know so that they're able to go look into it. But thanks for being so willing to like share your experience and knowledge. And
Yeah.
I look forward to the 24th.
Yeah, yes, we've got, remind me what are we going to be presenting on that? I'll drop a little ad.
It's the community.
It's technology, right? We're going to look at how service models can be sort of reimagined and redesigned when you leverage technology, an infrastructure to deliver support in the moment and place that support is needed. It's not just for the person served, it's also for your staff, which is increasingly so important and critical. So yeah, I can't wait to see you guys in just a couple of weeks and we'll dig in on that topic at that time.
Awesome. Thank you.
Okay, it's been a pleasure. Thank you all.